So as we continue along discussing specific movements with respect, or having specific movements be the central point in our network of meaning or in our semantic network with respect to our understanding of anatomy, we're looking at shoulder adduction. So the general preamble with respect to looking at the shoulder, although we're speaking about a specific motion, we still will continue to repeat that when looking at movements of the shoulder, you generally check the whole thing, the whole girdle, just because of how this ends up working. So the scapulothoracic articulation really being the relationship of the scapula to the body or to the body wall through muscles, not necessarily through bone-to-bone contact, aside from the AC joint. Then you have the clavicular motions, or the SC joint really being the only location where the arm is slung from the torso by a bone-to-bone connection, which means that a lot of this is very heavily muscularly involved. So although we may identify a shoulder adduction issue as the primary issue when looking at the shoulder, we still want to consider everything else to make sure that other things aren't contributing. Now, that said, you could make the argument that this is true of anywhere else in the body, such that you check everything and you treat what's not moving. That's correct, but what we're going to do is obviously focus a little bit more closely on the shoulder and where you would check in some kind of organized fashion after you've done a quick kind of gross motion, macro motion scan of the entire body to identify that, yes, the shoulder does have an issue that should be investigated further. And which shoulder? Is it the right? Is it the left? So after you've done your gross or your macro scan, you go into the areas that you found motion restriction. In this case, it would be the shoulder, and you would do a macro scan of the shoulder girdle, the arm as a unit, generally speaking. So our goals or our main objectives: a specific discussion of what shoulder adduction is, so the planes and axes, general discussion of the muscles that adduct the shoulder, general discussion of the nerves that supply those muscles, general discussion of the vascular supply. So that just ends up getting collapsed down into the neurovascular bundle in the case of the shoulder region because of how tight everything is. And it's a broad area, but in a small area at the same time. So there's large considerations as far as cognition is concerned, but it's not necessarily in a large spread out place. General discussion of the areas to assess and treat should shoulder adduction issues be suspected or reported. And then we obviously finish off with red flags and contraindications. So a lot of this discussion is very redundant with the other shoulder movements because the considerations are very similar. The thing that breaks out as being a little bit more clear is the particular muscles that would be more involved. So our quick overview of planes. So the sagittal plane is a 50% cut of the body left to right. Horizontal transverse plane is a 50% cut of the body top to bottom. The frontal or coronal plane is a 50% cut of the body back to front. Now, in the case of adduction, so adduction would be the arm is away from the midline of the body with respect to the anatomical position and being brought back towards the midline of the body. So shoulder abduction is taking it away from the midline. Adduction is taking it back towards, with the anatomical position being the point of reference such that the arms would be at the side and palms would be facing forward. So in the anatomical position, in a technical sense, the arms are adducted. They are adducted already. Whereas if they're anywhere away from the midline of the body, the act of bringing them back towards is adduction or adduction. Now, again, there is no clear actual axis for this to happen. There's a predicted axis or a hypothetical axis, because the glenohumeral joint is multiplanar and multi-axial just because of the shape. So you've got a ball and socket, so it can kind of go anywhere as long as it's not restricted by soft tissues, which it is, but it's multiplanar and multi-axial, so there's no clear axis there. The scapulothoracic movement, or the movement of the scapula in relation to the thoracic cage, is dictated by muscles because that's the attachment. So there is no clear axis there either. So the predicted axis, so this is happening in the coronal plane or in the frontal plane, but there's no specific axis. It is a predicted axis, or you'd be able to pin it somewhere based on what you were identifying, but that's not how it works. It works because of the angle of pull of the muscles that are involved. Now, with respect to the muscles that are involved here, you're not going to see them all in this picture, but it gives us a general idea of the region. So you have the sternocostal head of the pectoral muscles, you have the latissimus dorsi, you have the subscapularis and the teres major that are going to be involved in adduction of the shoulder. As far as nerves are concerned, with the sternocostal head, if memory serves me properly, it's more the medial pectoral nerve as opposed to the lateral pectoral nerve. The lateral pectoral nerve, I believe, is more involved in the clavicular head, but depending on the particular individual, it'll be a mix of the two. So don't take that as gospel, and don't take that as something to even think about. Think about the movement. The subscapularis is the upper and lower subscapular nerve. The teres major is the lower subscapular nerve, and the latissimus dorsi is the thoracodorsal nerve. So this ends up being collapsible into our discussion of the neurovascular bundle, but basically when the arm's up here, you're going to pull it back down this way with those muscles. So the pectoralis major, but primarily the sternocostal head, the latissimus dorsi, the teres major, and the subscapularis are going to be the muscles that do that for you. The neurovascular bundle, again, on account of the fact that although it's maybe a physically small area, say compared to the area that you'd have to think about for abdominal musculature as far as vasculature is concerned and as far as the neurology is concerned. So if you're thinking about the neurology or the vasculature of the abdominal muscles, you have to basically think from at least the clavicle all the way down to the pelvis, just because of how that area is set up. So the intercostal circulation, the intercostal nerves, the internal thoracic to superior epigastric circulation, the abdominal circulation to the word is escaping me, the iliac circulation, my apologies, things of that nature. You have to think that far. Whereas in the case of the shoulder, it's in a tighter physical area, but it has more than enough specific details to confuse cognition. So we're trying to reduce cognitive load here. So if you're thinking about the circulation, you're thinking about the subclavian circulation, the carotid circulation, and the axillary circulation, especially if you're thinking about how the arteries are going to be set up to feed the latissimus dorsi, right? You're going to have some flip backs, you're going to have some confusion there, you're going to have some essentially collateral circulation from other things, depending on the particular individual. You're not going to be able to predict this in a given individual, but what you're going to know is the general area, the neurovascular, or sorry, the neural bundle, the brachial plexus coming off of the cervical column, coming between the anterior and middle scalenes, going posterior to the clavicle. These are all in a very tight physical area, but there's enough to confuse cognition that if you identify the motion problem, if there happens to be mechanical interference with the function of the neurovascular bundle, dealing with that mechanical interference should predictably remove the problem with the mechanical interference. So you identify the motion problem, and then you're going to be able to more accurately interface with the problem as it presents itself. So again, we've just got this really quick overview of the neurovascular bundle because it passes in a predictable set of areas. And if there is a problem with shoulder adduction, which is very, very, very rare. It's very rare that you're going to have a person walking around with their arm out here and not able to bring it back, even just on account of gravity. So you're very rarely going to find a problem with shoulder adduction. However, if you happen to, then you're going to think about the general region of the scapula and the thorax and the shoulder. You're going to think about everything here because you've got to go pectoralis major, you've got to go subscapularis, teres major, and lat. You've got a large area to consider. And you're almost never going to find this. It doesn't mean it's impossible, but you're not going to find it much. But as with anything else in the region of the shoulder, you're going to check the whole thing in a organized fashion so that you can identify where the major problem is and where other minor problems are if they coexist. So as we have touched on quite a few times with this series on the shoulder, the areas of consideration for assessment and treatment, you're thinking about the clavicle. So although we're thinking about the pectoralis major and the sternocostal head, you're also, it's united with the clavicular head. So you think about the clavicle, with respect to how it interfaces with the scapula, how it interfaces with the scapula and the humerus. So as far as the neurovascular bundle, you're going to think about the cervical column, very generally speaking. You're going to think about the thoracic column and how that's going to relate to the ribs. For the sternocostal head, you're going to think about the thoracic column for how that is holding on to or in relation to the scapula, right? So the muscular connections there through the trapezius and through the rhomboids, all borders of the scapula. So the medial border, the lateral border. So in this case, the lateral border is going to give you some access to the latissimus dorsi. The latissimus dorsi, I said teres major earlier, but I made a mistake, but latissimus dorsi and the subscapularis, right around here, you're going to get access to that. So that's the lateral border. you're going to think about the pectoral muscle. So in this case, it's the sternocostal head, but you're not going to really pick that apart from the clavicular head. You're just going to be able to kind of grab in here. You're going to be able to work the pectoral region there. You're going to think about the ribs. So these things all become consistent highlights when working in the region of the shoulder, regardless of the specific motion problem that you have, because you may have an adduction problem and the arm could be quite far forward. So that becomes obviously pectoral, but then what else may be occurring, right? So is it being held up by something? If it's being held up, so if the person's walking over their shoulder like this and their arm's out here, well, then you'd also have to consider the trapezius. So in this case, if you check all borders of the scapula, if you check the pectoral region, if you check the ribs, the T-spine, the cervical column, and deal with whatever motion problems show themselves there, then you will effectively deal with the shoulder in most cases. As far as red flags and contraindications, known fractures or tears, you do not treat. You definitely don't treat that area. You may be able to treat the patient if you're very, very cautious and you don't put any extra pressure or pull on the area that is fractured or broken. But basically, known fractures, don't treat. Suspected fractures, refer out. If it comes back that there are no fractures or tears within that scan, then you can increase your level of confidence that you may be safe to treat, but you have to be extra cautious. Recent dramatic changes in cognitive functions, you don't have to pick these apart. You just have to know that if somebody's memory has changed dramatically in a short period of time, if their ability to speak, so speech has changed, if their ability to know where they are, anything like that, recent dramatic changes in cognitive function, that is an immediate red flag, send that out. You don't need to know what it is, you need to know not to treat it and to send it out. Recent dramatic changes in respiration could be a pneumothorax, could be an underlying lung pathology that neither you or the patient can identify, could be a heart problem that neither you or the patient can identify. But any major changes in respiration, recent and dramatic, is an immediate red flag, you send that out. It could be very emergent. It could be something that has gotten to a point where it's noticeable, where the patient tries to walk up a set of stairs and they're out of breath in a way that is abnormal for them. But either way, even if it's not something that is emergent, you send it out as if it was, right? Now, many patients may not necessarily be willing to present themselves to emergency services, and they don't. That's a bit of a gray area, but what you need to know is you refer that out and you don't treat it. So we want to make sure that you're not in situations where you are a danger to yourself or a danger to the patient.